sembra un angelo, nel freddo della sera, non vedo grandi cose, oltre la pioggia scura. Chi conosce Broadway, la vita che c'è sotto, dietro ogni viso teso, le storie d'ogni giorno. E per lei che il suo mondo, sì, con lei fino in fondo, e salirà su nel cielo, sempre con lei. La pioggia cade su New York City, scende fin dentro il cuore, mi lava l'anima. Ora li vedo andare via, ora li vedo andare su, guardali insieme che volano via. E per lei che il suo mondo, sì, con lei fino in fondo, salirà su nel cielo, sempre con lei. Sempre con lei, sempre con lei, sempre con lei.
Ragazzi, are you ready for the next episode? ragazzi, are you here?
Hello.
Ragazzi,
Oh, you have a nice shirt. This
yeah,
looks
today we have a very important match, and Galatasaray and Fenerbahce. If we win tonight, we will be the champion.
wow. But you know that your shirt is very nice because it's looking like the team from Roma. It's exactly the same.
Of course. But you know that this is precisely the same situation also here. Today we have the last match, and if PAOK, which is the team from Thessaloniki, wins this last match, gonna be the champion of Greece. So today it's a crazy day here in Thessaloniki.
Wow. Hai capito.
Yeah.
Allora, ciao Sebbi, ciao Costantino, ciao Nisa, ciao
Wow.
Emilio. Are you ready for a very, let's say, scary episode?
Scary. Yes.
Very scary episode.
Yes. Indeed. Yes, indeed.
Yeah. And maybe Sebbi, you like to launch the question of the week. What is the most difficult melanoma? Pink melanoma, lentigo maligna, melanoma in patients with multiple nevi, or the one I've never seen before? What is the most difficult? What is the most difficult for you, Nisa? Not easy, eh? Allora, pink melanoma is the winner, 60%. And
That would be my vote also.
yeah, and that's exactly the topic of today. Come on. We have to try to understand how to avoid missing a pink melanoma. Emilio, do you have news for us?
No, not really news.
No.
How can we avoid to miss a non-melanotic melanoma? Well, unfortunately, only by not looking for melanoma clues.
Yeah.
Exactly.
Do you have a nice paper to present regarding this topic?
Yes.
Wow.
Boom.
Let's see. I'm very curious.
So, the topic for today is pink melanoma. By the way, guys, I realized by looking at the literature that this is a quite under-investigated topic. There is not much, let me tell you. Of course, there are some big studies that we try to do concerning, in general, non-pigmented lesions, including amelanotic melanoma. Of course, in all these studies, amelanotic melanoma was usually just a small part of the sample because it's much more rare to find as compared to other non-pigmented tumors. Imagine non-pigmented BCC, so easy, so frequent, non-pigmented squamous cell carcinomas, the majority, non-pigmented angiomas, very frequent, but melanomas are not so frequent. And the literature is not so rich about amelanotic melanoma. And the paper that I selected to present you today comes from
the best journal there ever was.
You muted yourself.
Yeah.
From the journal. It's a nice paper from UK, let me tell you, that was published recently in the DPC, investigating precisely what we are discussing today, the features of amelanotic and hypomelanotic melanoma, including 50 cases. If you think that these 50 cases are few, let me tell you they are not.
No.
Why I say so? Because together with this paper, I will like to remind you another very famous paper that was published in another quite good journal, not like DPC, but quite good journal, the Archives of Dermatology, today JAMA Dermatology. This is considered maybe the hallmark paper for dermoscopy of amelanotic melanoma, a group effort multi-centric, of course, from many countries, led by Scott Menzies back then. That was in 2008. And in that paper, that is considered still maybe the most important, look, in the overall sample, 105 melanomas were included. Of them, 100 were not amelanotic. They were just not heavily pigmented.
Yeah.
So the number of purely amelanotic melanomas was 15, even though the study was multicentric, which obviously suggests that we are speaking about a not so frequent entity, and which also suggests that the number of 50 that I showed you earlier from this paper from UK is not a small number. So in this historical hallmark paper, as usually, Scott did a very thorough dermatoscopic analysis. You see how many parameters were evaluated. Of course, it's an extremely busy table to go through. Let's just see a couple of important things. I would say, first of all, we have the negative predictors and positive predictors. Negative means that when they are present, then melanoma is unlikely. And here you can see the list of these negative features. I would say I would like to stop just for a moment to, since we speak about amelanotic melanoma, to the presence of coma vessels in a regular distribution, or coma vessels as the predominant vessel type. This is a strong negative predictor for amelanotic melanoma. And the second is, the last one, arborizing vessels as the predominant vessel type of large or even small diameter. Again, this is a negative predictor for amelanotic melanoma. So that's a first conclusion that we can agree, probably, that when we see these two types of vessels predominating in the lesion, then the diagnosis of melanoma is not likely. But as I will show you, this is not also a rule without exceptions. This is a rule with which is mainly usually correct. Then, concerning the positive features, so concerning the features that are present in amelanotic melanoma, here you can see again that the table is extremely busy. Of course, many of these criteria are related to pigmentation, because as I told you, in fact, 100 of 115 of these melanomas were pigmented. So if we eliminate the pigmented criteria and we remain with the ones that are really seen in non-pigmented tumors, we can see that, first of all, there is here this description about the so-called pink color, milky red or pink color, which, if you look at the number, is probably the most frequent feature seen in a melanotic melanoma. No, the second most frequent. The first most frequent is the presence of vessels in general of irregular shape and irregular size. In terms of the morphology of the vessel, you can see already from the table that sometimes they are linear irregular, sometimes they are dotted, so 40% linear irregular, but 33% dotted, 22% dots globules of irregular size, and also 21% hairpin vessels. So many morphologic types of vessels can be seen in a melanotic melanoma, and pink color was suggested as a clue to diagnose amelanotic melanoma. This is a nice example of pink color, of an amelanotic melanoma with a pink color. But in general, at least to my eyes, and I would like to hear your opinion at this point, pink color is not really something that I feel that I can be based off on. First of all, it's tough for me, myself, to evaluate if there is pink color or not. Of course, in this example, okay, but this is just one perfect example of pink color. Usually, I find it tough to judge if there is pink or not. And then, second, I am not so sure that this pink coloration is not also frequent in many basal cell carcinomas, for example. Not to speak about Merkel cell or other rare things. What are your thoughts about this pink color?
Yeah, usually it's not present in dermal nevi or in seborrheic keratosis. So those benign lesions, which are, let's say, the main differential diagnosis and the more dangerous differential diagnosis, because if we miss a pink melanoma thinking that it's a dermal nevus, we send the patient home. But I agree with you. nowadays, I don't think that this is a very important criterion because it's very subjective. It's very difficult to assess.
Yeah. Very difficult to assess. Yeah. That's why usually when we speak about pink color, we show this image.
Yeah.
I mean, because it's one of the very few that we have. Then another thing from that study back then from Scott was a difference that we see in early amelanotic melanoma and late amelanotic melanoma. The difference is that, as you can see here in the table, in early less than 0.75, the most frequent vessel type is dotted vessels, 40%, while in thicker melanomas, then hairpin vessels account for 40% of the vessels that we see. So it's also a concept that as melanoma grows, the vessels at the beginning are usually smaller, dotted, sometimes also short linear, but small. And then as the tumor becomes more nodular, then the vessels become a little bit more elongated, often with curves, banded, hairpin type or coiled type sometimes. And eventually, we also see some crazy linear irregular vascular structures that are visible in this particular melanoma here that I show with my arrow. So that's something which appears to be rather correct. And now let's go back to this paper that was much more recently published in the DPC from a group of authors in the UK. A less busy table that we can follow. Again, there are some structures that are related to pigmentation. So if we focus first on the vessels, and if we focus on the last column, which is the total number of melanotic melanomas, you see that more or less everything can be present. 63% linear, 63% looped, 60% dotted. So more or less equal percentages for all vascular types. And 60% again, 63% of melanomas display polymorphous vessels, which means that 40% of melanomas displays monomorphous vessels, which is quite a lot, let me tell you. And we will see a few examples of melanomas that display only dotted vessels or only linear vessels or only hairpin vessels. And this is quite frustrating and annoying, okay? So the rule that we said earlier apparently is not a rule that applies in every melanoma. It's just the most frequent vascular type in early melanoma is dotted. The most frequent vascular type in late melanoma is linear irregular, but definitely there is a lot of overlap, in this. And now we'll see together a series of amelanotic melanomas, and I would like, with your help, to answer the question, what kind of vessels do you see here as the predominant type in this series of randomly selected melanomas? Let's start with this one. If I ask you, what kind of vessels do you see here? What would be your answer?
Loop.
Coiled glomerular.
Coiled. Yeah.
Coiled or hairpin, focally hairpin, coiled or hairpin. Agree?
Yeah.
Yep.
Yeah. Nisa, your microphone is off.
Coiled.
Coiled. Okay, coiled mainly in this melanoma. Okay, in the next one, what kind of vessels would you say that you see?
Looped.
Looped, hairpin. Yeah.
Mm-hmm.
The previous, a melanoma with coiled, this one, a melanoma with hairpin. This one, very
Linear.
Very ugly melanoma.
Looped and linear.
Looped and linear, yeah.
Linear. Looking a lot like a seborrheic keratosis, I would say. Yeah?
Yeah.
It could be easily
Bad.
bad.
Yeah, I mean, I would probably think it's a ZK.
Yeah. Really tough one, because there is also the keratin, which complicates even more the scenario. But the vessels here are looped. Okay, good. Next one. What kind of vessels do you see in this melanoma?
Branched serpentine.
Branched serpentine. In other words, arborizing mainly, and also some shorter and smaller linear vessels. So that's really frustrating. In the next one, what kind of vessels do you see here?
Dotted.
Dotted.
A few dotted vessels, because in the largest part of the lesion there are no vessels at all. There is just an hemorrhage, and there are some dotted vessels focally, mainly the peripheral part.
Yeah.
In the next melanoma, what kind of vessels do you see?
Linear.
Linear irregular.
Linear, yeah. Linear for sure, irregular, yes.
Not.
Yes.
Polymorphic, yeah.
Because actually, I recently have an identical one on the same spot, exactly looking the same.
Yeah. And in the next one, in this one, what kind of vessels do you see?
Polymorphic.
Yes, but what
Polymorphic.
what kind of morphologic types?
Dotted. Linear dotted.
Yeah.
Linear, dotted.
Coiled.
Yeah, some coiled. Yeah. In the next one, what kind of vessels do you see?
Branched.
Serpentine.
Serpentine. Yeah. So
That's
based
a
on
melanoma.
all this, can we reach any kind of conclusion, which is the vascular pattern of amelanotic melanoma that we can rely on?
Of course
No.
not.
Nothing.
No way. I mean, melanoma can do whatever it likes in terms of the vascular pattern, whatever it likes. Of course, it's not frequent that we see a vascular pattern perfectly reminding BCC, like, a very large, very thick, arborizing vascular pattern crossing the center of the lesion and so on. But even this can happen, not frequently. But except of this, which is infrequent, all the other morphologic types are maybe seen, and this is reflected in the studies. If you see the percentages, they were very equal, very similar one to the other. So we cannot trust at all to the vascular pattern in order to detect amelanotic melanoma. And of course, that's the reason why we always recommend to our colleagues not to do it, so not to try to diagnose nodular amelanotic melanoma based on the detection of linear irregular vessels or anything else, but instead we recommend to accept the limitations of morphology here and to excise all the lesions that cannot be safely classified as one of these 4 diagnoses that you see here, precisely because the vascular pattern is insufficient.
Yeah.
And this is not much better when it comes to flat amelanotic melanoma. Again, let's do the same. We will see 4 lesions, trying again to answer what kind of vessels do we see in each one of them. So in this one, what kind of vessels do you see?
Dotted.
Dotted and linear.
Agree, dotted at the periphery and linear in the center. I would say linear in the center and dotted at the periphery. Yeah. Okay. In the next one, what kind of vessels do you see?
Dotted.
Dotted and coiled.
Dotted and some coiled, but dotted predominantly. Yeah. In the next one, mainly linear. No.
Yeah. Linear.
Serpentine.
Yeah. Mainly linear, and some of them also with a few ramifications. And in the last one.
Yeah. Very blurred.
Yeah.
This is
Short,
blurred.
short linear.
So again, can we conclude anything? Can we base our judgment on assessing?
Pink and brown make me frown.
What?
Pink and brown make me frown.
Yes.
Yes, this could be a nice quote, a nice try to do better, please, guys. Yeah, remember the quote.
Please suggest quotes. Yeah. So the point is that again, we cannot base our judgment on trying to decide if the vessels are dotted or short linear, or there are also coiled. Is this a monomorphous or polymorphous vascular pattern? That's not a safe strategy. In my view, what's more useful by looking at these 4 images is not to assess the vascular pattern, but what's more useful would be to notice that in all these 4 flat amelanotic melanomas, there are no erosions and no hyperkeratosis. And what I consider this important because erosions and hyperkeratosis are very frequent in the tumors included in the differential diagnosis. So erosions, in my view, is the best clue to diagnose superficial BCC. Scales, together with coiled vessels, is the best clue to diagnose Bowens. So when we don't see scales, when we don't see erosions, and there is a flat lesion with a vascular pattern that we find difficult to assess, then it could be a flat amelanotic melanoma, and this is a reason to be careful and do biopsy. Last thing from this paper was the fact that short white lines, and I suppose that the authors were referring to the shiny white lines, were found in 79% of 80% of amelanotic melanomas. And it's true that in the study by Scott back in 2008, shiny white structures were not evaluated. So it could be that it is, in fact, a useful additional clue that could help us, especially in amelanotic melanoma, which is so much featureless. I am not so sure if they are that much frequent, 80%. I'm not so sure. I think they are a little bit less frequent in amelanotic melanoma. But anyhow, it's clear that when we see them, so the image on the right is the melanoma we saw earlier, the last one, the last flat one, that was really, really featureless. But you see that with polarized light, we can see these white shiny lines. And of course, on the left, also, we can see a lot of white shiny lines. So that's maybe something that could be additionally helpful to recognize a melanotic melanoma, although I still insist that the safest way is to follow the rule that we repeated several times.
But it's very interesting because while preparing my cases, in order to comment, to add something to your paper, it's nice that we came to the same conclusions. So maybe I will just immediately do my cases, because then we go to the questions, because in my view, it's a very nice repetition, more on a practical level. So let's say why we didn't miss this series of amelanotic melanomas that I selected since the last few years from our database. Okay, so why did we did a biopsy? Okay, so look at this lesion. Clinically, of course, it's quite visible. Let's say it's a lesion which is catching our eye. Let's say so. Yeah.
This one is also pink, I would say.
Yes. So partially flat, nodular in the center. Okay. So it's a large lesion. And dermoscopically, we have, in my view, the most important criterion why, in my view, we could not miss this one. It's because there is remnants of pigment. You know, even in the most pink lesion clinically, if you look dermoscopically, you still find some pigment, some remnants of pigment, especially 12 o'clock and 11 o'clock. You see some globules, you see some remnants of brown pigment. Then you see some reticular depigmentation, you know, lots of white lines. You said 80%, maybe it's too much. I agree. Maybe 80% is too much, but still, this is quite an important criterion to evaluate, which was not formally assessed by the former studies. And then, of course, we have plenty of linear, irregular vessels, in some way serpentine, yeah, in some way. But of course, putting everything together, this does not look like a BCC. This looks like a very suspicious lesion. But the remnants of pigment, in my view, is the most important criterion here. Okay. Look at this other lesion here. Clinically, oh my God, this is a disaster, in my view, because no way we could think clinically about a melanoma. We could think about decubito, some kind of, vascular lesion or whatever. But, in some parts of the lesion, you see some irregular vessels. But here again, you see that there is remnants of pigment. And in my view, again, this is the most important finding. Yeah. The most important finding is that in this lesion, by looking carefully at the lesion, you find remnants of pigment with dermoscopically. So again, this lesion was not missed because of this particular finding. Let's see the third lesion. This is a nodular, relatively small lesion. There is some ulceration, maybe. I don't know. I'm not sure. It's a young lady on the arm. And let's see dermoscopically. Although we thought it could be an hemangioma clinically, but I mean, in dermoscopy, we don't see lacunes. We see some vessels. We see linear, irregular vessels, again, white lines, white areas, and that's it. Here in this particular case, there is no remnants of pigment. There is only linear, irregular, polymorphic vessels and white lines, okay? So why we didn't miss this one? We didn't miss this one for one specific clue we try to apply. And the specific clue is that when I'm dealing with pink lesions, if, as you said, Emilio, before, if I cannot be sure about a specific benign diagnosis, I have urgently excised the lesion. If I'm not sure if it's that this is an hemangioma, if I'm not sure this is a dermal nevus, or a seborrheic keratosis, I have to excise it urgently. And this was again a melanotic melanoma. The rule is valid not only for nodular pink lesions, but also for flat pink lesions. Here we see a flat pink lesion located on the arm of a 65-year-old man, quite fair skin, as you can see from his lenticels. There is an ulceration in the center. My main clinical diagnosis is superficial BCC, but dermoscopically, no signs of BCC. Usually, superficial.
This is the worst one of all because there is an ulceration.
Yes, there is an ulceration in the center, but usually superficial BCC is producing multiple erosions. Anyhow, since my differential is including BCC, even though I'm not sure, of course, the lesion was excised. And as we said already plenty of times before, when we cannot be completely sure that this is a BCC, we cannot use the priority we usually use for BCC. So, okay, 3 months. But if we are not sure, we have to excise it in the main priority 1, and this was again melanoma.
In my view, this thing that I heard you speaking about it recently several times is very, very important.
Yes.
And we have to find a nice motto for this because often, not often, sometimes melanoma is looking quite a lot like BCC. Of course, not perfectly, not like the classic BCC, but displays focally some features that guide you to think that it could be a BCC. So maybe the motto should be that a BCC which is not clear-cut could not be a BCC or something similar. That's for another time.
Yeah. So let's go with the last 2 cases that I prepared. This is even more scary in my view, even more scary, because this is a young man, I would say 25 or something, with a brand new nodular pink lesion on the mouth, partially hemorrhagic, crusty. And here you see, for sure, the pigmentation is a blood crust in blood hemorrhage, bottom part, but the top part is showing linear serpentine vessels. Yeah, of course, I'm not thinking that this could be a BCC. I think that the most probable diagnosis could be here pyogenic granuloma. But again, I have a rule. And the rule is I don't I excise always with the histopathological confirmation any clinical pyogenic granuloma. Okay, so when I think clinically that this could be a pyogenic granuloma, I have to excise it urgently and I have to send it to the pathologist. This was polypoid melanoma. A disaster.
So
Disaster.
again here, although you say that you didn't believe that this is a BCC, yes, but somebody could think so, because I mean, it's it's a translucent nodule.
Yes.
It's ulcerated. Dermatoscopically, you see vessels that are in line with BCC. So it would not be unreasonable if somebody would say, okay, come on, it should be basal cell carcinoma.
Exactly. No, but clearly, because of the age, I was more prone to think about pyogenic granuloma, but still, BCC is a valid option. Again, if we apply rules, we are able not only to not to miss them, but also to excise them urgently. And the last case is this one. This is not a young lady, but still, it's a lesion which is, in my view, a seborrheic keratosis clinically. Irritated, traumatized seborrheic keratosis. But if you look, if I look dermoscopically, clear cut, these are polymorphic vessels. This is too much for an irritated, traumatized seborrheic keratosis. Could it be a congenital nevus? I don't know. It could be, but still, this is a lesion in which I have no idea. I'm not sure about a specific benign diagnosis. So that's why I have to excise it urgently. And this was again polypoid melanoma. So a bad diagnosis. So at the end of the day, we come to the same conclusion as you came, Emilio. Why we don't miss, or we try not to miss, melanoma, pink melanoma in the practice. First of all, because we check carefully, not only clinically, but also dermoscopically, the few criteria which are available in a melanotic melanoma. Few of them: remnants of pigment, atypical vessels, white lines, ulceration. Okay, I didn't include in this list pink, milky red areas. Why? Because I also agree this is not really a relevant criterion anymore. But the second and even more important rule is that pink lesions, both nodular and flat, must be excised if a benign diagnosis or an inflammatory disorder is not clear-cut. So if we are not sure, we have to treat pink lesions with the maximum respect. Okay.
This is a good quote also.
Yeah, I think so. So I think there are a few questions, right, Emilio?
A couple of. The first one is, do you think that the pink color is more visible, more evident from a clinical point of view in comparison to other benign pink lesions than dermatoscopically?
Well, the pink hue is either way due to the vascular blast. So depending on what kind of dermoscopy you're using, if you're using contact polarized dermoscopy, then by the pressure alone, you will decrease the vascular hue. So it may be not as prominent dermoscopically. But I think it's more or less the same if you use non-contact.
Yeah. We have, by the way, very nice quotes. Vessels in pink, think. And another one is nodular pink, remove in a blink. And there is another one. It's not paranoia if they are out to get.
From me, love and I love it.
Yeah.
Stop and think, pink, BCC or melanoma link. Interesting.
Another question is very nice, very interesting and important question is if there are differences in white shiny lines between BCC and melanoma. That's something that we have to answer. And in fact, I saw the question a few minutes ago, and I can just show you something which will facilitate the answer. So, of course, white shiny structures are very frequent in basal cell carcinoma, very, very frequent.
Also dermatofibroma, like this one.
And also dermatofibroma, and also in benign tumors, not all, But in BCC, they are really quite frequent. Theoretically, as you can see in this example of BCC, the white shiny structures in BCC are somehow thicker, not thin lines, but thick lines. And we use the term strands in order to highlight that they are thicker, and also blotches.
I thought this is a dermatofibroma. No, it's a BCC.
It's a BCC. You can see the blue clots here.
Yeah.
You can see the
Yeah.
blue clots.
Yeah.
So it's a BCC. Yeah. Of course, it could be a dermatofibroma if it didn't have the blue clots. This is again a basal cell carcinoma. Look that theoretically the structures are a little bit thicker. But I have to say, so if we want to look them in comparison, BCC on the left, melanoma on the right, the answer to the question is that in BCC these features are thicker. But I have to say that also in melanoma, especially when melanoma becomes a little bit more nodular, also the shiny structures become more thick. It was described also in a nice study, and I can just show you one only example of an example that cancels the rule of thickness of the lines, because you can see that also on the left. This melanoma, the lines are quite thick. They would be rather defined as blotches or strands. So yes and no is the answer to the question if there are differences. Theoretically there are, but it's not, these are not differences that we can trust in order to discriminate between basal cell carcinoma and melanoma.
Emilius, it would be exactly my answer. So in flat melanomas, yes, we usually see strands perpendicular in between them as they were originally described. But
Streaks.
as soon as there's a nodule, pardon me?
Streaks, not strands, streaks.
Streaks. Perpendicular in between them, but as soon as it starts getting deeper, then you start seeing blotches, you can see strands, you can see all kind of shiny white features.
Yeah.
George asks if they are strictly amelanotic without melanin, or if it's if the pink is pheomelanin.
No, it's just pink. There is
Just
no
pink.
pheomelanin.
No, the question is if it's absence of melanin or paucity of melanin, or just pheomelanin. I'm not so sure.
Pheomelanin can be still seen as a very light brown pigment. Yeah. So here we have no melanin at all.
We have quite a number of proposed plots, I have to say. That's nice. We'll have to put them in the Kahoot. Wonderful. Any other question? Is in melanoma also the vessels are always thicker as compared to what, Elisa? As compared to BCC, they are thinner, not thicker. In general, in melanoma, usually the vessels are not very thick and are not very, very long, especially at early stages. In advanced nodular melanomas, they might become long and elongate and bended in a very strange way, the so-called linear irregular. Sometimes we also call them corkscrew because the convolutions are very, very crazy. But usually they are not very thick. Again, we cannot base our assessment, in my view, on the thickness of the vessels.
I like very much this one. Pink lesions, not sure if benign and you need advice. This is when you must excise. Wonderful.
Terpene melanoma can also be detected in pink melanomas.
Opa, Sebi has to say something.
Go, Sebi. Wonderful. Fantastic. Another question was if hairpin melanoma, probably you mean, Elisa, hairpin vessels, if they can be detected in pink melanomas. The answer is yes. We showed a couple of examples. So you cannot exclude the melanoma because you see hairpin vessels. Of course, it's not the most frequent vascular type, but they can be found. And with this, I think that we have answered all the questions, unless I missed something. Hello!
Oh,
Hello, Rudino.
We missed him. We missed him today.
Yeah.
Wonderful.
Wonderful.
So, how do we move on? Konstantinos,
Yeah.
I think that you have no, you don't have, do you have cases?
yes, absolutely.
I understood differently. Okay, but
No,
let's go.
no, but
Let's go to
I think
Nisa.
that we
Okay, let's go to Nisa first, and then
Okay.
we conclude with you.
Can you see my screen, dear
Yeah.
friends?
Yes.
Okay. So this is the first case. This is on the leg of a lady. And you see we have white lines and some sort of dotted vessels, linear and looped vessels, and a little bit brown pigmentation at the periphery. This is the non-polarized node. In comparison, polarized and non-polarized. And this is 405 nanometer. You can see the vessels more clearly. So what's your diagnosis here?
We have a poll. Yes, we do.
Yeah.
BCC, dermatofibroma, amelanotic melanoma, Bowen LPLK.
Yeah.
And the winner by far, 83%, is a melanotic melanoma.
Mhm.
Yeah, okay. Let's go back. Can we go back? Yeah. Actually, I also prefer here melanoma because I didn't see ulceration, at least focal erosions. There was nothing there. Polymorphic vessels, white lines. So we excised it. And histopathology was superficial basal cell carcinoma here, fortunately.
But
It was
Sometimes
on the
BCC.
which was the
Yeah, it was on the leg. Yeah,
leg,
because
leg.
yeah, it's very different. At least I expect some sort of erosions, but there was no ulceration or erosion there. Okay, another case. This is on the leg, solitary one.
Yeah, there is some brown.
What's your diagnosis?
Again, same options: BCC, dermatofibroma, melanoma, Bowman, LPLK.
Yeah, this time we have coiled and dotted vessels, white lines.
Melanoma
Again, the majority vote for melanoma, but this is not a melanoma. Look at the color of the background,
orange.
how it looks like.
Well,
What's the color? Pinkish,
Bit orange.
orange, pink orange. So what can it be when it's
LPLK.
orange?
Planus-like keratosis.
Yeah, this is lichen planus-like keratosis. The color was the clue here, because when we see orange color, we should suspect first for LPLK due to the heavy lymphocytic infiltration. But we should for sure excise it to rule out melanoma, because it could be also melanoma.
and urgently.
Yeah.
Exactly. So both of these lesions are lesions to excise. In the first case,
Yeah.
Yes.
you cannot
Yeah.
be sure that
Yeah.
it's
Yeah. And this is the same patient. She has 2 lesions on the leg, and they are both pink lesions. One is flat, the other one is nodular. So let's have a look at the dermatoscopy. Okay.
But
And what's your diagnosis for each lesion?
BF or melanoma.
This is not the correct option, Sebi.
So let's say
This is the correct.
Here we are.
Yeah.
The first BCC, the second melanoma, both BCC, poorly differentiated SCC, LPLK on the left, BCC on the right.
My God.
I guess that both melanoma will be the most voted answer.
Both melanoma is very, very pessimistic.
Yeah, but this is the most voted answer.
Okay, for sure we have to excise both of them. Interestingly, the second one was a nodular melanoma with a breast of thickness of 2.5 millimeter, and she had lymph node metastasis, which is extracapsular involvement. The first one was the BCC. So really, they are very weird cases, very challenging for me, because the second one at least looks like a basal cell carcinoma, because we have serpentine and branched vessels, and big polygonal white shapes on the background. We don't observe thin white lines of melanoma. So it was a challenging one, but it was a melanoma. The first one was a superficial basal cell carcinoma, which looks like the first case. And this is my last case.
And as you can see,
A young patient.
As you can see, Nisa, when we miss the multiple erosions in superficial BCC, no one can make a diagnosis. I mean,
yeah, for sure, yeah. And this is the last case. Young patient, history is 2 years. It was moderately firm palpation, and she came from another center, and the doctors performed a punch biopsy. So I knew the diagnosis when I saw the patient, because she came with the histopathologic diagnosis. I'm explaining this because this ulceration is due to the punch biopsy.
Yeah. Well,
BF or
dermatofibroma, the second option is melanoma.
Optimistic. I feel
Which one?
I feel optimistic as well, Jerry. Yeah.
So let's see the results, Sebi. So I think the majority vote for melanoma. Yes, it was a melanoma. And generally, I show this example in my presentations. When I see pink lesions with white lines, I press with the plate of the dermatoscope. In melanoma, these white lines are still very visible. But in dermatofibroma, the background turns to white structureless coloration. And these white lines generally disappear in dermatofibroma. But in melanoma, we still see these white lines. So as you can see here, we can observe the white lines here. And another dermatofibroma case looking like the previous one. And when I press over the surface, I just observe white structureless background. All white lines disappear. And here is the comparison of two cases: white lines, white structureless areas. But for sure, for lesions like this, we have to take a biopsy, because we know that really some melanomas are looking like dermatofibromas. And it was a nodular lesion, and breast of thickness was again more than 2.2 millimeter, and there was mitosis. So, and the patient fortunately doesn't have a lymph node metastasis, but that can happen later. So a biopsy should be done in these cases. Another melanoma case with white lines, and when I press the surface, just brown coloration, and still we see the white lines, not white structureless background. This was an amelanotic melanoma, and this was a basal cell carcinoma. As Emilios told, erosions or ulcerations is a good clue for basal cell carcinoma, especially when they are located in the leg, because we have very challenging dermatoscopic findings. Normally, we don't expect to see dotted vessels in basal cell carcinoma, but it's quite common on the leg.
Yeah, absolutely.
Molto bene. Very nice. I mean, very scary cases.
By the way, from this case of the melanoma that was punched in the center, that gives us also the opportunity to say that from a management point of view, this is a very reasonable thing to do. So you have a nodule, your differential is between dermatofibroma and melanoma. It's quite large. So you are in doubt, and before doing the entire excision, you punch. It's absolutely okay.
Yeah.
No problem at all. And yeah, wonderful. Konstantinos, are you ready, my friend? But
Absolutely, my friend.
wait a moment. No, but we forgot. No, you show the cases first, and I will say it afterwards.
Okay.
Wonderful. So, pink, think, blink. All those things. Can you see my screen well? Because I'm having some internet issues.
Yeah.
Perfect. So this is my first case. Of course, this is, I think, pretty evident. I want to highlight, of course, the remnants of pigment. As Jeppy was saying, they're usually pretty evident. Sorry. And also, the whole idea is to get melanotic melanomas before they reach at this stage. This was an 11 millimeter Breslow thick melanoma, of course, with ulceration, with 35 mitosis, I think, something like that. And the patient had already, of course, metastasized. But this is a case that I would like to share with you. This is the clinical overview. Of course, a patient with a history of, I think, 2 primary melanomas, a typical mole syndrome. You can see a very high-risk patient. And this is the clinical close-up. Emilios, if you would have to guess which is the more disturbing lesion, which one would you say?
This one here. I cannot show you.
Tell me.
Right on the right at 3 o'clock. Yeah, this one exactly.
This one. Excellent.
Could be.
But now I want to show you the follow-up on 3D imaging. This is with 6 months apart. Can you spot the ugly duckling?
Yeah. Yes. No.
Lower
the-
part. Yeah, correct.
This one is the new one, also highlighted by the artificial intelligence. I have to admit that I missed the lesion because usually when I see all these high-risk patients, I first do a total body skin examination, total body dermoscopy. I absolutely missed the lesion, and technology is what drove me to it. Here you can see how it evolved. It's a completely new lesion. And this is the dermoscopy, well, with that, but this is the actual dermoscopy. Are you worried about it?
Wow.
Yeah. So 0.3 millimeter melanotic melanoma, totally a melanotic melanoma, highlighted to us by technology, which, I mean, can be useful from time to time.
Yeah.
Next case, 34-year-old gentleman with this new nodular lesion. Ugly, huh?
Yeah. Yeah.
Have any?
Still dermatofibroma versus melanoma, of course. Yeah.
Are you feeling optimistic, Jeppy?
It's too big. It's too big. But why not? Yeah, could be still a big dermatofibroma.
It's an aneurysmal dermatofibroma confirmed by biopsy.
Yeah.
And this patient, this is one of the, I have to admit, probably one of the most difficult patients that I have. She has an eruptive speech nevus syndrome developed when she was at her early 30s. She's now 40s. And also melanoma. All these lesions that you see are speechoid lesions.
Mm-hmm.
And here is where she had her melanoma, which was a superficial spreading, interestingly, not a speechoid melanoma.
Mm-hmm.
And I would like to draw your attention to these lesions. Are you interested? Are you worried by any of them?
Mamma mia. This is
Mamma mia, yes, probably.
terrifying. This is the scenario where without a mole mapping, without a digital dermoscopy follow-up, no way to get out of this problem, out of this management.
Exactly. So she's now followed at 6-month intervals, and during these 6 months, she developed 11 new spitzoid-looking lesions. However, this drew our attention due to the polymorphous vessels, and actually this was a melanoma. But of course,
Very difficult case.
yeah,
Well,
the patient comes in and
this particular scenario, also histology is not, you know what I mean?
of course,
Yeah, it's a matter of interpretation of the pathologist, and yeah, but whatever.
absolutely. Absolutely. But the thing is that all of these are spitzoid, all of these are ugly looking, and you're just trying to keep up with whatever you can.
Yeah.
I saw this case the previous time. It's not very in focus because when I pressed, like it was totally lost. This new lesion on follow-up of a high-risk patient with a history of 2 primary melanomas. This was his 3rd. Hypomelanotic, maybe only. Pardon me?
Yeah. Another melanoma, maybe, huh?
Yeah, melanoma. It is a melanoma. It's his 3rd primary, highlighted only, of course, by follow-up and total body photography, because it was new. This case is not entirely pink, but I really liked it because I would love your input. This was sent to me by a colleague because she was pretty horrified by it. What would you say that your diagnosis is here?
BCC or something like that?
Sure.
There are some.
Very, very unusual seborrheic keratosis, or of course, melanoma as well.
Yeah,
Bravi,
this is the optimistic thing.
Yeah.
Bravi, it was a seborrheic keratosis. And I mean, the first time I saw it, I gave it, because I was quite sure it was a seborrheic keratosis traumatized, I gave
Clonal
like a...
one.
Yes,
Was it a clonal seborrheic keratosis?
Clonal sub-K, yeah. Like I did a follow-up in 15 days with the topical use of corticosteroids, but it didn't improve. It became like even worse. So I had to excise at the end, but it was a seborrheic keratosis. And here it's an inverse quiz. So this is the dermoscopy. Any ideas? New lesion.
Lymphoma. Lymphoma? Lymphoma.
It's
yeah. So
squamous cell also?
Yeah, squamous cell as well. Yeah.
Leishmanias, maybe? Lymphoma.
It's metastatic squamous cell carcinoma.
Yeah.
Because there are also some white circles visible at the periphery.
Yeah. Excellent. Yeah. So this is a metastatic patient who also developed cutaneous metastasis. And this would be my final case, I think. Patient, again, with a history of melanoma, presents with this new nodule on the back. This is the scar of his melanoma.
Metastatic melanoma.
How thick was his previous melanoma?
1.7.
Metastatic.
Could be, or
not a primary.
But could also be several other things.
Yes.
Like
so
primary, very improbable. But
what did you say, Emilio? Sorry.
Could also be some other rare things like AFX or Merkel.
Fibroxanthoma? Atypical fibroxanthoma, maybe?
AFX, a typical fibroxanthoma. AFX is a typical fibroxanthoma.
So it did come back as a typical fibroxanthoma. Excellent, Emilio's.
Yeah.
Wow.
Oh, and this is my last one. Super rare. Just for the discussion of it, totally pink on this toe of an older gentleman, and this is dermoscopy.
Poroma.
Ecrine porocarcinoma. Metastatic.
Metastatic.
Yeah.
Never seen a one.
Yeah.
Metastatic one.
What do you
Great
mean
case.
metastatic? Distant metastasis.
Distant metastasis with total lymph node dissection and relapse, and right now has lung metastasis.
Wow. Wow.
Yeah.
Wow.
Impressive.
So these were my pink leads.
Wow, very nice cases. Very nice
Very
cases.
nice cases. Yeah. Very nice. Of course, unfortunately, guys, there is some pessimism in these cases. We cannot avoid it. We
Yes.
speak about amelanotic melanoma. We cannot be very optimistic,
No.
although we try. Any other question? Why, Nisa, that's for you. You said that the white lines in dermatofibroma might disappear when you apply pressure. Have you any idea why?
It's generally white structures.
In general, white structures. Yeah, in general.
Homogeneous white structures areas.
Okay, I don't see anything else. So I think that it's time for me to show you something interesting concerning one of our sponsors, which is Canfield. And today I will not spend these few moments to speak about the devices, because we many times spoke about the wonderful devices that the 2D imaging, the 3D imaging device, and so on. But today I would like to say a few words about the software, which is really helpful for clinicians to use. And I will show you some functions, not the AI functions, which we always speak about the AI function, the automatic recognition of changes or the automatic classification. But today I would like to show you some functions that facilitate what we really do every time we evaluate patients. And this software offers a good interface for all these functions. First of all, the dashboard organizes the images in a way that you can see all the images of the same lesion in a single column. Look, for example, number 1, the column with sequential images, and in the horizontal, in the horizontal panel, in the row, you can see different lesions of the same patient. So this facilitates a lot, both the comparative approach and also the sequential monitoring of lesions. Then, of course, all photos, notes, and attributes associated with the lesions are available for instant review and comparison side by side. And in addition to this, Dermographics can locate lesions on the overview image according to clinicians' own criteria, and a spiral diagram mode can be used again for the comparative approach. So you see many lesions together, and you can compare among them in a very easy and fast way. And also, something which facilitates the comparison, the markerless tracking automatically. You see that it aligns skin surfaces from 2 body maps, so that you can compare the clinical image precisely at the spot that you're interested. Last thing, very fascinating and brand new, the Dermographics on the web. This is a tool that empowers patients themselves to check for changes between office visits. Your patient can access the overview and close-up images through a secure web portal, and this helps the patient to identify changes that might happen rapidly in between the visits. Just showing you one example, the patient can access the 3D imaging that you had performed in the previous visit, or the 2D imaging that you had performed in the previous visit. And this gives a way to involving the patients in the follow-up procedure.
Perfetto. Grande. So,
and
last part of the episode.
Slowly moving to the last parts of the episode. Wait a moment.
Yeah, last part meaning 2 main things.
2 more things.
Yeah.
Any idea which will be the first thing?
Well, Penelope?
Bravo, Giuseppe. Bravo. Penelope, 5 wonderful cases as always for us, starting with a case for Nisa, which is this 20-year-old male. Yeah, Opa is a little bit Greek. Very unsightly erythematous papules on the cheeks, symmetrically distributed for 1 year. That's the clinical aspect. This is dermoscopy. Come on, we can.
Granulomatous rosacea.
Yes,
Yes, yes.
granulomas, granulomatous rosacea.
Nowadays, we became expert of granulomatous rosacea.
Exactly. Nice focal orange structure.
Which is, by the way, very difficult to treat.
Very difficult to treat. I told you.
Yeah.
Very, very difficult to treat. Not responding so well to retinoids, and of course also to anything else.
Yeah.
It's a tricky thing. Next case for Konstantinos. Annular lesions on the forehead for 3 or 4 years. That's a quite challenging one, I would say. That's dermoscopy. Tough. In the image on the left.
Morphea, maybe.
Morphea, because it's hypopigmented, but in the dermatoscopic image on the left, I think that maybe there is somehow something useful.
Discoid
Looks
lupus.
GLEs.
Do you see orange color at all on the lower left image?
Oh, yeah, at the periphery. Yeah, I just realized it. Yeah.
There is orange color there.
Yeah.
And some linear
Sarcoidosis.
vessels. This was a case of sarcoidosis with an annular distribution. Very
case. Beautiful.
very nice case. Then the next one for Geppi. 4 odd, asymptomatic, small maculopapular lesions located on the tip of the nose appeared in the age of 18, and that's the dermatoscopic image.
Oh, Jesus.
You know, no, the clue is there, but you need some time.
Jesus.
Really?
It's not the
Discoid
predominant.
lupus.
It's not the predominant thing you see, because the predominant thing is follicular plaques. But if you notice carefully, they are also outside the lesion follicular plugging.
Yeah.
But the clue is there. You just need a few seconds to see it.
From my point of view, this is discoid lupus.
Orokeratosis.
Come on.
Where is the porokeratosis?
Come on.
No, it's there.
Ah, come on. It's very challenging. Never seen.
Unbelievable.
Never saw a porokeratosis.
Yeah,
Mercedes
case.
Bambi. Bravo, Mercedes.
Really? Bravo. Fantastic. Okay, then the next case for me, no MF history, asymptomatic red brownish plaques symmetrically distributed on the cheeks and temples for 3 years. We can see the clinical aspect that the brownish color is visible, or gray brownish is already visible from a clinical point of view, much better visible dermatoscopically surrounding follicles.
Lichen.
Beautiful.
Lichen planus.
Pigmented, lichen pigmentosus, or lichen planus in the face of in the late phase. Very reasonable guess, and it's, by the way, the correct one here. Brown grayish dots.
Penelope, you must publish this case. You must describe it. It's so good. It's so beautiful.
Yeah.
So beautiful.
Yes, it is. It's true. And the last one for Sebi, in a very good health, no medical history, fairly firm centimetric nodule on his left cheekbone of recent onset. That's dermoscopy.
Oh.
Leishmania. Leishmania.
Pseudolymphoma, maybe.
What?
Leishmania.
Pseudolymphoma.
Pseudolymphoma is a nice, very nice guess. I also
Pseudo, yeah.
Leishmania because of the follicular plugging.
Sarcoidosis.
Yeah. And finally, the closest of all was Sebastiano, who said pseudolymphoma. In fact,
Lymphoma.
that was not pseudo, real lymphoma with orange color again, and white circles surrounding yellow plugs, and of course some linear vessels that might be seen in.
Because you know what is the problem? We forgot the clinical. If you look at the clinical, Leishmania is becoming less probable.
Correct. No ulceration at all. Wonderful. Very good. And now, my friends, last thing to do for today is to play. And let me tell you that I cannot conclude if my Kahoot today is easy or not. I think it's easy, but I might be wrong.
Okay.
Before the Kahoot, of course. Wait a moment.
By the way, we lost the match.
You lost the match.
You
It's
lost the
finished.
match.
Yeah,
Lost
we
the
lost
match.
the match.
Oh,
Yeah.
It's finished.
We're sorry, Nisa.
che peccato. Bene,
get
bene,
ready to
bene,
join.
bene, bene, bene.
Get ready to join. And join. Hola. Hola is the single player for the moment. That's but not anymore. Now we have more than 3. So again, the problem came back, as you can see, but I don't care about it.
As you said in the last episode, it's not a problem.
It's not a problem. Exactly. So let's start in 3, 2, 1, 0.
Vai, 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 vai. Vai, 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 vai.
2, 1. First, the poll for the quote. We have 6 proposals for today. Vessels and pink, think, think, think. When you see pink, stop and think. Nodular pink, remove immediately. Dirty pink, remove it quick. Pink lesion, not sure if benign eyes, you must exercise. While this is inside, don't be fooled and exercise.
That's so funny.
And the winner is marginally. When you see pink, stop and think.
Wow, bellissimo.
But to be fair, I think that this quote exists.
Yes.
It was said by
By Debbie.
by our friend from US.
Robert.
Robert Joel.
Robert said it.
Yes, yes,
I think so.
yes, I
Yeah.
think as well. Wonderful. Perfect.
Fantastic. Okay, let's see our 5 cases for today. That's the first one. That's the clinical. It's a non-pigmented nodule. Fits also with the topic of our discussion. Here you can see, I'm so annoyed when this happens and the quality of the image becomes like this,
Yeah.
because these are perfect images in reality. Anyhow, I cannot do anything at this point other than going to the question, which is, which image was captured with polarized light? Let A, B, both, or none?
It's an easy question. I would skip the diagnostic question, right?
So, marginally correct answer for A was with the correct answer. Unfortunately, guys, it's much better seen in the real photograph, the white shiny strands and blotches, which are very evident in lesion A. By the way, guys, diagnosis?
No idea.
Say one, say.
BCC.
What?
No.
BCC.
BCC, yes, BCC.
Sì, veramente.
Yes. Very good. Cancan, Dr. Siller, and Ruveida are in the first 3 places, which brings us to case number 2. That's the clinical. This is an interesting dermatoscopic image.
I like it.
You like it?
I love it.
Love it a lot.
Perfect. This is a nevus, a melanoma, a seborrheic keratosis, or a BCC. you think it's an easy one?
It's a special
No,
type,
but it's a nice one.
special type of lesion.
Very good. It
Oh,
was
no,
an easy one.
bravi. Look, I mean, my God, our guys are so good. I mean, this is
The
very
audience is amazing, yes.
oh, wow, wow.
Clonal seborrheic keratosis, eh?
Yeah.
Excellent. Cancan remains first, Dr. Silla remains second, and Belize is now third, which brings us to the next one. Oh, a wonderful case, very recent one. That's the clinical. You see the size,
Yes.
1 millimeter.
Okay. And wow.
And
Yeah.
that's
Nice.
and this is a nevus melanoma ink spot lentigo basal cell carcinoma. I made the question a little bit tough, no? Oh,
And wow.
very tough.
Come on.
That
Come on.
was very
Everybody,
tough.
everybody's going to miss this one. Everybody.
Well, in reality, not. I mean,
Yes,
maybe.
but Pink Spot was my, it was my.
By the way, do you believe that this was not in situ?
No, come on.
Really?
Unbelievable. 0.4.
No.
Wow.
I double checked. Of course. Double checked. In a patient with previous melanoma, by the way. Nisa, your microphone is muted.
That's impossible.
Yeah, but for sure it was checked 2 and 3 times.
Let
By
me
the
say-
way, the only thing not fitting with an ink spot lentigo here is the absence of network. Usually in ink spot, we expect to see a black network, but of course.
Yeah.
Good. What happened here? A disaster. EV came first, GLI second, and TAHA third, which brings us to the last one. No, it's not the last one. It's the fourth one. 2 lesions in the same patient. This is the clinical aspect of 2 lesions. This is dermoscopy, the big brother and the small brother. And the question is, which is melanoma? A, B, both, or none?
Pessimistic.
Oh, 53 correct answers for both. Although the one on the right is a very baby, newborn, just born melanoma. The one on the left is much more advanced, of course. So both melanomas, correct. And let's see what happened. Eve is still first, Taha and Dr. Lapik in the third place, which brings us to the last question of the day. No, it's not the last question.
Yes.
It is. Yes. That's the clinical. 2 photographs. And the question is, which image was captured with polarized dermoscopy? A, B, both, or none?
Rudy.
And the correct answer is, of course, A, found by 83 of the participants.
Great.
By the way, diagnosis?
Melanoma.
Melanoma in situ, yes. Melanoma in situ.
Yeah. But just to give a clue for the polarized, non-polarized, you can see the bubble, how better it shows on the B because it's more superficial.
The what?
The bubble. The bubble.
The bubble. Yeah. But also the point is that you see that in the polarized mode, everything becomes more brownish, a lot of more light, everything becomes more brownish, while in the non-polarized, we can see also the
Grayish.
gray and or bluish coloration. Very good. And now, this brings us to the podium for today.
Podium.
Dr. Lapik, second place, Taha, and first place, 2.
Eve.
Eve
Bravo, Eve.
or Eve, or
Bravo, Eve.
let's see if we have Eve with
One-
us.
Well, the episode was very tough, but let me tell you, it was lots of nice cases, lots of interesting points. Very good. And a very nice quote, by the way.
Taha says that it's second time second. Come on, Taha.
So next time you will be the winner, Taha.
Yeah. Insist.
Yeah.
Yeah.
So I don't see Eve.
Remember Laura.
Laura won and now she's relaxed. Yeah. Wonderful. So we don't see EV for the moment. So anyhow, congratulations. It could be Elisa Zavato.
Taha is coming.
Or
Taha.
Eve Lovenstein, most likely.
Yeah, because Elisa wrote in the chat, thank you very much. But we don't have the first, but we have the
Hello.
second.
Hi, Taha.
I am so excited to be here.
Taha,
Congratulations.
you have
Thank you. Teşekkürler hocam, çok sağ olun.
Grande,
He's a
grande.
Turkish guy.
Bravo. Congratulations.
Thank you.
Keep up. Next time we will have you again on air.
I will. I hope
Because
so.
you're going to be
Thank
the
you.
first one.
Thank you so much. Thank you, dear professors.
Who is Ev?
Well, we didn't find
Bene,
you.
ragazzi, un bacio grande.
See you next
Bacio.
Sunday, guys.
Ciao,
Thank you,
ciao.
everybody.
Ciao.
Bye.
Send us your cases.
Next episode.